For doing this.
Oh, my pleasure. I'm moving myself.
Right. Okay. Just close this so I can see. Actually, why don't you just tell them when to start?
Good morning. Did everybody get enough to eat? Yeah. Because there's no more.
Okay, go for it.
No, you're first.
Oh, okay. Yes, we're a little discombobulated today, so thank you for being at sports coming in. We didn't think you wanted to have breakfast out in the rain this morning, so all the best laid plans. We brought everybody to Phoenix to enjoy the beautiful weather and the sunshine and meals outside, so we're hoping it'll clear up for lunch and we can sit out in that beautiful Paseo West. But you can blame it on Don and myself because the weather gods never like us. When we've traveled, we've caused we have fires and volcanoes to erupt, hailstorms in the summer, so you don't want to travel with us. But we are all here. So we hope you enjoyed your first day. I know everybody's exhausted already. Good. So every year when our community gets together, there's just this amazing positive energy, and even as our community expands in size, I feel like it's still there. So thank you to all the newcomers for becoming part of our family.
Yes, and by the way, we've already had our share of injuries here in the place, and so no more. Anyway, we want to thank all of the 300, I think it's 61 registered attendees from 11 different countries, including Canada. Did you know that? Yeah, thank you. I wanted to hear from you. Anyway, I know that you all have busy lives, and we appreciate that you come here. This is our largest group of attendees ever, and what a wonderful way, yeah. We started out with 84 20 years ago, and look what we have. This is absolutely amazing. This is a great way to celebrate our 20th anniversary, whether you are a patient, caregiver, and medical professionals, and we have a wonderful group of medical professionals. I'd like to hear a hand of applause for them. Thank you. And we would like to have all of you share with everybody at your table. Not necessarily the food, but the thoughts. So, Ricky.
All right, and again, I'd like to thank our community and corporate sponsors without whom we couldn't hold this conference, so thank you so much. And I hope all of you enjoyed the clinical trials session yesterday. All the pharmaceutical talks were fantastic, and if you have any questions for any of them, they're around all day out here in Bender Village.
Okay, and we would like you to continue wearing your name tags.
That's right, I cut that out.
Oh, she cut it out? Really?
Sorry.
She doesn't tell me, but blames me.
Okay, that's right. You're right. Here, use this one.
Okay. During today's general session, there are note cards on the table for you to jot down any questions, and then there will be runners who will pick up these note cards. So you'll see them on the table. Just a reminder, Kelly Shepard, he's kind of the short, ugly guy. He is a sibling of a PSCer and will be taking candid photos. We will also be videotaping our general sessions, so feel free just to listen and not take your own notes because you can view it later. Also, it's a long day. We have 3 general sessions and Ask the Experts, so
feel free to always get up. If you want to go to the restrooms or just need a break, go find a quiet spot, go back to your room, and come in and out whenever. You won't bother anybody. I also want to give a reminder that if you didn't go to Albert Fung's virtual reality of the liver yesterday, he is on the second floor in Ocotillo B all day long. It is worth stopping in there and seeing his presentation. It's really cool. Please mute your cell phones for the day, which I forgot to do mine.
Yeah.
Okay. Should I just do this
Yeah.
faster? Okay. During breaks and meals, please stop by the shop and also by Vendor Village, as I just said, and please take a moment to visit the community space and add your thoughts about some of the questions we have up today. Please don't forget to stop by the PSC Partners Registry table. Talk to them, whether you're part of the registry already or not, please stop by. Think about filling out our health equity survey, which we have running. And another thing I think we mentioned quickly yesterday, if you stop by the registry table, you can put your name into a box there, and tomorrow morning we're going to have a drawing. We have 4 copies of Sandy Perlman's wonderful book about her journey. It's a book not to be missed. Another thing, if you're staying on Sunday night and you'd like to join us for a casual meal at Rustler's Roost, which is just up on the hill here, please send an email to contact us at pscpartners.org so that we know how many people are coming. So we'll meet up there at 6 o'clock, and there's a little van that goes from the lobby up there if you don't want to walk. What did I add here? Okay, this morning we have 2 general sessions. In the middle, when do we have we have a snack, and the snack is our traditional yogurt sundae, which we have every Saturday. And then, yes, okay, I will remind you again after the session, but right before lunch, we're going to try to do a group photo, and we're hoping to do it outside on the staircase, which I'll tell you about, but that's only if it's not raining. Otherwise, we're going to have a new venue, hopefully. And then after lunch, you will attend your Ask the Experts session. And again, you chose that during registration, but it's listed back here with the room. You can check. And then, let's see what else. After the day's session, you'll have an hour and a half, which you will need to rest up and to get ready for the big night, our gala dinner. If you'd like to wear a costume Roaring 20s, we would love that. Get in the spirit, but you don't have to if you don't want to. And then afterwards, we have karaoke, which actually also has been a tradition here for years. And even if you're not a karaoke person, just come and be part of it. You don't have to sing. We have a great time. So I think we are ready to start the first session, titled Moving the Needle Towards a Cure, 20 Years of Progress in PSC Research. And we've had another change because Dr. Chris Bolus had to go home. His mother-in-law was ill. So Dr. Dan Pratt has been kind enough to fill in for us. Dr. Dan Pratt is Assistant Professor of Medicine at Harvard School and Director, Harvard Medical School, and Director of the Autoimmune and Cholestatic Liver Center at Mass General Hospital. Yep. I have a little bit more, hang on. Dr. Pratt's particular area of clinical interest is autoimmune and cholestatic liver disease, including PSC, and he's head of the PSC registry at Mass General Hospital. Thank you.
All right, well, it was an honor to be asked to fill in the rather large shoes of Dr. Bolus, but delighted to be part of this session because really wonderful speakers here, and so I'm excited to hear each one of them. And the first one up is Dr. Nate Baggett, and Nate has been an important part of the PSC Partners family for many years and has really a remarkable story to tell, and so we're delighted to hear Nate. Thanks.
Good morning. Like many of you, I was diagnosed with PSC by my local GI doctor. I was 20 years old, in college, and was alone in my dorm on a Monday afternoon when I got the phone call from my doctor telling me about this disease that I had never heard of before called PSC. Like most of you, the next thing I did was get on Google, and I saw words like no cure, no treatment, and liver transplant. And I was terrified. I shut my laptop, turned on my favorite music, and I remember weeping in my dorm. It felt like a death sentence. It felt like my hopes and dreams for my future were over. But that was 15 years ago. These years have not been easy. I remember the horrible itching the constant fatigue, the recurrent infections that many of you also deal with. But life went on. I graduated from college, I traveled, I met my future wife, Anne, who's here with me today, and was lucky enough to be admitted to medical school. During medical school, I got sicker to the point that I was listed for transplant in 2015. The next year, my cousin stepped forward and donated her liver to me. And I had hoped, like some of the people here who have had really smooth transplants, that I would sail through transplant surgery, discharge, and move on with life. But that wasn't the case. When you think about the complications that come with transplant, I checked the box of essentially every one of them. I had bleeding, infections, and other complications, and in total spent hundreds of days in the hospital, over 20 surgeries, and I went to our friends in interventional radiology over 70 times for different procedures. It was a lot. It was never easy. I still say that being a patient is the hardest thing I've ever done. Now, 6 years later, those complications and my life with PSC seem like somewhat distant memories. Since then, we had our daughter, Lucy, who's now 3 years old, and nowadays, rather than worrying about my health, we play chase and play make-believe, and those are what our days are spent with. So I hope in sharing my story, you hear that life can go on with this terrible disease and with chronic illness. Even with some of these really tough complications I faced, multiple transplants and all the complications that followed, there's still hope for a better life after PSC. When I was sick, I started saying that life doesn't have to be perfect to be wonderful. And certainly, looking across this room, everyone here is a testament to that as well. Thank you. Thanks.
Thank you, Nate. That was wonderful. And I feel like with all of our speakers today, they don't need introductions. They're just an amazing group. But next up, we have our keynote speakers. Dr. Tom Karlsen will be speaking to us. And as you all know, he is the co-chair of this conference this year. And his research in PSC has really made a huge difference in terms of our understanding of the disease and future treatments as well. But just briefly, Dr. Karlsen is the leader of the Norwegian PSC Research Center at the Institute of Clinical Medicine at the University of Oslo and co-founder of the International PSC Study Group. So we're really excited to hear his talk today. Dr. Karlsen.
Thank you very much for the kind introduction and also the challenge of providing you an overview of 20 years of international PSC research in 30 minutes. It would have been easy if I had 5 hours available. This will be busy, so fasten your seatbelts. At the bottom of the slide here are my disclosures, and at the middle of the slides you can actually see PSC. To the left you have normal bile ducts looking into the bile ducts, and to the right this is what PSC looks like. And I'll go straight to the point. What are we trying to achieve with PSC research? I'll be showing several plots like this, and I want to explain what it tells. So along the x-axis here are years, so this is time. And along the y-axis are percentages. And what it shows is really that with time, most of the, over time, PSC slowly progress. So the percentage of people with PSC living with their native liver decreases. You need a liver transplant at some point over the years, but it's really, really, really slow. After 20 years here, more than 50 people with PSC, actually 50% of the people with PSC still have their own liver. But there is this downward trend. This is a figure showing a Dutch PSC population, and I also illustrate here a milder form of PSC called small duct PSC, which actually shows a different disease course. It's there, the disease is never going away, but it's behaving better. There is no cholangiocarcinoma or less cholangiocarcinoma, and most of the patients, they actually don't need transplant. And fundamentally, what we are trying to achieve is to shift this bad PSC into a good PSC with the research efforts that we are doing. In the transplant setting, PSC is common. I work at the transplant center, and in Norway, PSC is the most important indication for liver transplantation. I hope, and I have this dream, that by the end of my career, we no longer see PSC patients on the transplant waiting lists. We don't see you on the transplant waiting list. Actually, if we didn't have PSC patients on the transplant waiting list, I probably would retire from research today. Here are some numbers. PSC seems to be increasing over time. In the general population, it's rare, 1 per 10,000 approximately. These increasing trends are probably due partly to increased recognition. We have MRCP, better tools, etc., so we're finding more patients. But there is also some alignment here with what are the trends in general for immune-mediated diseases, including inflammatory bowel disease, which seems to be increasing like PSC. Despite being rare, PSC is an important disease. For the patients, it's a bad disease. As you can see here over time, there is a significant shortfall in terms of what we call quality-adjusted life years. It basically means that you're feeling bad with time. And in terms of health economics, it's an expensive disease, so it should be of interest to the health systems and the politicians as well. This is what the scars of the bile ducts look like. And you can have such scars from a variety of causes. There are many things that can give similar scars. And this led to speculations by some that PSC could be a mixed bag of many, many different diseases. But there is this one particular form of PSC which has this propensity to also have concurrent inflammatory bowel disease. In Northern Europe and North America, around 60–70% have IBD. So not everybody, but there is this propensity. Even in Japan, as you can see to the right here, they have 2 different types of PSC. They have an older age group of PSC, which doesn't really have IBD, but in the young age group, it looks exactly like the PSC that we see in the West. And this PSC, to me, is one disease. It behaves very variably, you all know that, but it's one disease. And it has particular features. The inflammatory bowel disease of PSC shows particular features. It's more on the right side than on the left side. And if you do molecular studies, which have been done, these are the Chicago data, you can see that there are particular genes in the bowel which are more common in IBD and PSC compared to normal IBD. And we also had actually seen this from the genetic study, looking at the whole genome. PSC is different from regular IBD, and it's a disease on its own. This is a little bit my perspective to these 20 years of PSC research. I graduated as MD in 1997. I did a lot of other things, but in 2004, I started this PhD in immunogenetics in PSC. In 2010, we had the inaugural meeting of the International PSC Study Group in Oslo. You can see me taking notes here. I was the secretary at the time. And this group is now growing. This was the meeting in Stockholm just 1 month ago, where everybody came together. And it's in this context much of the research has been performed. And these researchers that I showed you in this picture, they form a very key ingredient of PSC research. And many of them, when you talk to them, they have a little bit of a different perspective to research than you might find in, I would say, a general researcher population. There are many reasons why you can do research. You want to make a career, you want to have a good job at a good institution. But many of these researchers, they feel actually that they are on a mission. And they are on a mission to solve this significant problem, which some has denominated the last black box of hepatology, meaning basically that in liver diseases, there are many things we can now do and we can deal with. PSC, we're still struggling. And this spirit, in many ways, has also shaped the way we work in PSC research. Efforts are largely collaborative. People try to help each other within the International Peace Study Group and other groups. I also think it's worth mentioning the role that philanthropy has played in bringing a momentum to PSC research. PSC is a rare disease, doesn't necessarily get the priority competing with heart disease, brain disorders, etc. And there has been some significant installments from families, Hagen family, Resnick family, Halloran family, that has helped generate momentum to bring the research to the status that it currently has. And this also goes with the support that has been given by the PSC partners and other patient organizations over the years. Pharmaceutical industry has been hesitant. They think PSC is a difficult disease, fair enough. But they are slowly coming on board, as we saw also yesterday. Most of the research in PSC actually happened the last 20 years. If you look into the literature, there are 8,000 PSC papers. I think I read all of them. 6,000 of them were published in the last 20 years. And if you take the bigger perspective to what happened over these decades, it's not really an old disease. We started recognizing the disease in the 60s and the 70s. We had ERCP. And only in 1980, we had the disease definition coming simultaneously in 3 papers from the Mayo Clinic, Oxford, and Oslo. We studied the disease variability, how it associates with various phenomena, including cholangiocarcinoma, throughout the 1980s. In the 1990s, we started becoming interested in how common actually is this disease. This is what epidemiological studies mean. We started doing pathophysiological studies. We wanted to understand why the disease arose. We focused on bile acid toxicity largely, and also this relationship with inflammatory bowel disease. And we had what I call here the first generation clinical trials, which was largely focusing on URSO, which led to the widespread prescription of URSO in PSC. Throughout the 2000s, we had genetics. We started figuring out how to tell whether PSC was severe or not severe through these prognostic models. And we had this delineation of PSC and PSC IBD as a distinct entity. PSC is a disease on its own. It's more than a complication to inflammatory bowel disease. 2010s, we saw the emergence of the microbiome studies, gut microbiome studies, and not only looking at clinical prognostic markers, but also specific biomarkers for disease severity. Biomarker studies was very popular throughout the 2010s. And we had what I call second-generation clinical trials, basically meaning that we studied a large number of new drugs in the same way that we studied URSO in the old days. Throughout the 2020s, its research has largely been flavored by technology, omics, not only genomics, but proteomics, metabolomics. You heard about these omics, big data collections. And we are seeing slowly the emergence of what I would like to call third-generation clinical trials, where we're basically scrutinizing drugs, also trying to look at new endpoints, new ways of assessing efficacy, which I will come back to. I've been very much interested in disease mechanisms. Why does this disease arise? And you can see here, I split this diagram here in 2 halves. There is the left half, where you have this hypothesis-driven research, which is, the classical type of research where you have an idea and you go to your laboratory, you test the idea, either you were right or you were wrong. To the left or to the right here, you have what I call hypothesis-free research, where you basically say, we don't really understand what's going on here, so let's just collect a whole lot of data and see what it means. And this is very largely technology-driven. As technology has evolved, the better the granularity and the visibility we have with the old technology. You have bad visibility with the new technologies, which are improving every year. You get better visibility. First, emphasis, as I told you, was very much linked with this hypothesis that there would be something leaking from the gut with the IBD into the liver and causing a reaction by the immune system and the fibrosis that we see. Not so sure there is so much of a leakage in PSC, and of course there is this paradox that the fibrosis in PSC does not occur along the blood vessels coming from the gut. They actually appear around the bile ducts. There's also been a large volume of research related to bile, which is a very toxic fluid. It is supposed to digest food. And of course, if you're transporting, as the poor bile ducts are doing, this very toxic fluid, you need strong protective mechanisms against this toxic fluid. And there have been various theories on how there could be deficiencies in these protective mechanisms. There's also a large volume of literature based on the crosstalk. The immune cells, they talk to the cholangiocytes. It's not a friendly conversation, it's a very aggressive conversation. And this aggressive conversation between the immune cells and the cholangiocytes actually what is driving the development of this fibrosis. And depending on which laboratory you work in, you would be focusing on different types of cells, but certainly this is a very important field of research. We started the genetic studies, as I already alluded to, and I think I will want you to pay attention to that figure because I will be back to it later on. But in principle, what we figured out with the genetic studies is that there are not really PSC genes. We find a lot of genes that are involved in PSC development, but they are the same genes that we see that are involved in inflammatory bowel disease and also, very importantly, in other autoimmune diseases. So I think that the main outcome of the genetic studies in many ways, paradoxically, was to tell us that PSC is an autoimmune disease. Recently, it's become very popular with so-called spatial technologies. You can, in a 3D, very sophisticated, refined way, tell how even single cells distribute in a tissue, how they interact, how they behave. And there's been a large volume of literature on the liver. I just want to make one key point here. PSC is a bile duct disease. It's not a liver disease. It's a provocative statement, but if you think about it, it's probably correct. And I think that there is now also an emergence of interest in applying these technologies to bile duct. Finally, the circle is closing here with the microbiome research and the linking with the gut. We have, thanks to these technologies, now the possibility to scrutinize the microbial flora of the gut, in which there are many, many changes. There are also some very specific bacteria, Klebsiella, Veillonella, and Enterococci, that you might have heard of, that seems to be involving in disease physiology. And also these changes lead to the production of particular chemicals, which may be harmful to the liver and involving in PSC development. So why are we studying all of this? Why this interest in this pathophysiology and the disease mechanisms? The key point is what we are looking for here are molecules or cells that we can target to dampen these processes, to make them less active, to make them less aggressive. And this is really what then aligns with this overarching mission that I started out by telling you about, making a good PSC, making a bad PSC into a good PSC. So how are we doing that? With drugs. And there has been a large number of drug trials and drug testing over the years. This is a slide summary where you can see here, I will be pointing to the one of the screens so that I won't be flipping back and forth. You have the bile acid-based therapies at the top. Some bile acid and also some molecules which are involved in bile acid regulation. You have the PPAR agonist, bezafibrate. You might have heard of fenofibrate. We heard about elafibranor yesterday. You have immune targeting drugs. You have antifibrotics. And certainly there's also been a lot of research on antibiotics. If you look at these categories by broad, for some of them, for the bile acid therapies, for the PPAR agonist, and for the antibiotics, something seems to be happening. There is some impact of it, which may actually be beneficial. We see that ALK-Phos go down, or maybe some fibrosis markers go in a beneficial direction. For other categories, like the immune modulation and the first antifibrotic, cetuximab, there was not really much going on. Then comes the question, what does this going on mean? What does success look like in a clinical trial of PSC? This is a very critical question. What does successful clinical trial in PSC look like? These are clinical trials in ursodeoxycholic acid. And if you look at alkaline phosphatase, it looks like a success. ALK-Phos improves all over. However, if you go into the impact on this survival in this overarching objective of making PSC move from this bad to a better version, you have to look here at the y-axis. It's only 0.8, so there's not really much of a change with time. And actually, if you use the high doses of urso, you may actually be worse off generating a better PSC than you started out with. So whether this is a success, we don't really know yet. We're not sure. And there are other perspectives to what success could look like. This is a different type of study. Don't worry about the drug. The key point here is alkaline phosphatase doesn't change. It's stable. So there's nothing really happening to ALK-Phos. However, fibrosis biomarkers are going down. And we know from other studies that we have performed that if you have high fibrosis markers, ELF or ProC3 that you may have heard about, you have a bad PSC. If you have low levels of these fibrosis markers, ELF and ProC3, you have a better version of PSC. So whether this is a success, well, we're not really sure yet. I think that this lack of capacity currently of us telling you whether this is a successful trial or not can lead to two very important, I would say, mistakes, scientific mistakes. I would like to make a statement on vancomycin. I know it's a controversial topic, but currently, from a scientific perspective, there is not enough evidence to claim that vancomycin works. It certainly is doing something. I'm not saying it's not working, but we don't know enough to start prescribing a drug. And this commissioning of drugs, this prescribing of drugs, basically out of desperation because we have nothing else, is not really the way that I would like to see us move forward in PSC clinical development. Also, you can make the reverse mistake if you don't really know what success looks like. These are all the immune targeted therapies that have been tried over the years. including the therapies that we're using for IBD, infliximab, adalimumab, vedolizumab, and tofacitinib. And there is not really much happening, but then again, are we studying these drugs in the right way? Do we really know that they do not work? And I would say we're not sure. So we shouldn't discard them. So we can end up starting to use drugs for which there is insufficient evidence, and we can discard drugs which are potentially efficacious based on this current lack of capacity to tell for sure what a success looks like. And there are many things we want to achieve when you're talking about success in a clinical trial. Hopefully, of course, we would like to see improved normalized blood tests, but more importantly, we would like to see less scarring of the bile ducts, longer time until liver transplantation, ideally never in the lifetime. I think that's what this initial figure I was showing you is talking about. It's talking about, okay, you have your PSC, but you never get a transplant in your lifetime. You want to relieve symptoms, you want to preserve quality of life, you want to avoid side effects, and this is important because you would be treating patients over decades. And you have to account for IBD, CCA. Ideally, you would also like to reduce CCA risk with the therapeutics. And this is a 20-year-old figure, which I made during my PhD, published only in 2017. And what it shows and illustrates is a little bit the difficulties that we are dealing with in assessing this success in these clinical trials. At the bottom here, you can see slowly there is this increase in fibrosis and scarring of the liver. So there is a progression of the disease. Then, if you look at symptoms, biochemistry, IBD activity, it's going up and down. So if you're doing something here, it's very hard to tell whether these things that goes up and down actually happens because of the drug or because just that's how the PSC is. It's going up and down. And of course, we are improving. We are getting better. We have more stable marker now. That's what these biomarkers are all about. We have these blood-based fibrosis biomarkers, ELF and PRO-C3, less fluctuations. We have elastography. We also have microbial biomarkers. So we are getting better and we are improving. Still, I think that the key challenge, and this is something we are currently studying, is how can we tell when you are intervening here in a drug trial for 3 months, 12 months, 24 months, that this actually has an impact 10, 15 years later? How can we know that? And that's where these natural history cohorts that you will have heard about or will hear about come into play. You have the WIND initiative, which you are running. You have the FICUS from the IPSCSG. We have the SCAN PSC, which is funded by the Halloran family. We have an older Swedish cohort. We have the Dutch cohort. And in total, more than 6,000 PSC patients are now being followed very, very carefully with all these different biomarkers, trying to tie them up to what is really the clinical relevance of the changes that we see in these biomarkers. This we need to know. And when we know that, we can actually go back and tell also something about drug efficacy. Also, what we can study in these cohorts are the patient experiences, the symptoms, quality of life. There is a variety of forms available. We're trying at the moment to make sort of an orchestrated package of quality of life and symptom assessments in PSC. And certainly, if you are applying therapies in PSC, you would like symptoms to go down, quality of life to improve. And this is really, then closing the loop here from the initial figure of the therapies to this overarching aim that what we want to do with the data from these natural history cohorts and the biomarker assessments is that when we see some changes in some of these biomarkers, we will know, okay, we can say, yes, this changed. We know that this means changing a bad PSC into a good PSC, which is what we really want to do. So throughout the disease course of PSC, there are many things that can happen. There has been research over the last 20 years in many of these areas, a lot of progress in inflammatory bowel disease, liver diseases in general, bacterial cholangitis, and I will not go into all of these events. I will dwell a little bit on cholangiocarcinoma. It's a sensitive topic, it's a difficult topic, I know that, but it doesn't help not talking about it and ignoring it, at least not from the researcher and the doctor perspective. And the message that I will try to convey to you here is the message of hope and of progress. There is a lot of activity in cholangiocarcinoma research, mostly from the oncology field itself. So we as PSC research do not really have to worry about this because this is being taken care of. But there are also people with crossover interests like Jesus Banales, who is running this European network for the study of cholangiocarcinoma, which is actually somehow a misnomer because it's actually running also very international studies all over the world. And they are doing studies similar to the ones that we would like to see happen in PSC, where you actually ideally would like to see prevention. Certainly you would like to see early detection. And with your early detection, you would like to see treatment. And one key message and one key outcome of research over the recent years is really this point on surveillance, which means that you are monitoring, you're trying to pick up on the cholangiocarcinoma as early as possible. And a key outcome of these studies, even the poor version or the version 01 that we are currently using of surveillance with blood tests and annual MRIs, it works. We see less deaths from cholangiocarcinoma with this surveillance. There's a challenge with surveillance of cholangiocarcinoma, and there's also, which I will discuss a little bit in this figure, because current algorithms, they are focusing on early detection of the cancer when it's there. Ideally, we would like to identify the pre-cancer stages, the early stages, like you do with cervix screening in women, for instance. The problem in PSC then is that the changes early on in cholangiocarcinoma development, they look very similar to those that occur because of the immune reaction itself. So you have these funny cells in the bile ducts that you can see here, low-grade dysplasia, and they can be funny because of the immune reaction or because they are actually starting to develop into something which you don't want to see. There is a little bit more of, and then they start to look even more funny. You become even more sure that they are having really the propensity of malignancy, and those are the ones that you want to detect for interventions. And to help us to distinguish all of that, we have now a variety of tools available. There have been a lot of development within DNA-based early detection methods, FISH initially, which you may have heard of. Now we are using mostly next-generation sequencing, which is like, more modern genetic technologies, and this helps us in this way. In Oslo, we have been focusing a lot on bile because we think it's logical that this would be a sensitive method because bile are so close to the cholangiocytes and so-called methylation markers. There are also blood-based methods, proteomics, you can use microRNA, metabolomics, variety of technology, and you can even look into urine. And my point here is that we have actually at the moment, I think, more than 10 such tests which look very promising. I would have loved to have them applied if I had PSC on myself. However, they are not available in the clinic. And I think this is another thing which we have to deal with in PSC research over the coming years. We have to work not only with drug companies in drug development, we have to work with diagnostic companies in bringing these methodologies into clinical practice. They need particular types of data that the regulators will be happy with. You need somebody to produce them in a particular way because they have to be clinical grade, et cetera, et cetera. So we need a different type of model than what is the scientific model. So I think that there are now a lot of tests, and they will be available, and they will arrive in the clinic over the coming years. Certainly, and finally, for cholangiocarcinoma, there has happened a lot with regards to treatments over the last 20 years. If you go 20 years back, this was like, a surgical problem, very difficult surgical problem. You had very poor methods for fixing the problem. Today, however, there is a lot of options available. Surgery has improved a lot. That's very important. You have chemotherapy, not perfect, but all the time improving. You have also immunotherapy. And this is, I think, something very particular with PSC because some oncologists would be concerned about prescribing immunotherapy in PSC because of the concurrent autoimmunity that you have with the IBD, et cetera. I think that this is a research responsibility for the PSC community to really figure out how safe and how to do this in a safe way so that this option also remains available for PSC patients. We've been using it without problems in several cases. You can also do local therapies, and importantly, from genetic technologies, you can actually find particular mutations in the genes, and you have now rapidly evolving algorithms for cholangiocarcinoma therapy. So the situation today with cholangiocarcinoma is completely different from 20 years ago. There's so much more we can do. I will end my talk with some more philosophical statements. One is, two of them are learnings, and then there is a small statement on cure. So I have two learnings. The one is from genetics, and I will not tell you what this is immediately. There are some dots here. You can see you're back in 2005. If you go to 2006, there are some even more dots. Suddenly these dots start to connect, and there are more and more dots, 2009, dots and connections, 10, even more. What this is, these are actually genetic researchers. These are people working on genetics. Because what the genetics researchers realized throughout those years was that they had to collaborate, because otherwise their data wouldn't be any good. You couldn't trust their results. So they were forced to collaborate. And what we did from that learning was to establish the International PSC Study Group. We sat at a genetics meeting in Hanover in 2009 and said, why are we only collaborating on genetics? Why aren't we collaborating on everything? So that's how we formed the International PSC Study Group in 2010. It's actually arriving from the genetics collaborations. Then there is something about time here. Obviously, starting your PhD, you think that you're going to solve a problem completely. So starting my PhD, of course, I had the idea that when I was done, there will be no more problem with PSC, and I could move on to other adventures. That didn't happen, unfortunately. I'm sorry. But then, of course, we had this 10-year program in Oslo. We had a significant grant, and I made a plan. This is my plan. We would first figure out the genetics, because then we could actually work on these genes and understand how the disease arose. And when we had understood all the disease mechanism, we would know which drugs to use and how to cure the disease, and we would be done after those 10 years. Unfortunately, we weren't done, painfully enough, and we're still running the Norwegian PSC Research Center now in the second installment. And you might ask yourself the same question. Okay, we provided 70 grants, almost $6 million. Why aren't they done yet? Why haven't you fixed this problem for us? And this is something which I think, it can be seen from two different perspectives. Of course, it's a bit pessimistic that things take time. You would like to have a solution tomorrow. But of course, if science worked that way, that, okay, you have this disease, you do some research, and then it's gone, we wouldn't have any diseases. This is not the way science works. Science works more slowly and also in leaps. There are some breakthroughs, and this is an illustration of what happened in hepatitis C, and I think it gives you an indication of both these things. You have the identification of the virus in 1989. This was a breakthrough. Then there was a lot of research, and in 2014, you could actually cure the disease. So the disease is no longer a problem. It's a problem, but you can fix the problem. And this is actually, I think, a good perspective to what we are dealing with, and at least it has helped me not feeling too bad about not having fixed PSC yet. So what about cure? Taking out a piece of those 20 years, 2006 to 2016, we were doing a lot of genetic studies. We found a lot of genes. Don't worry about all the details, because if you take one step back, and I always do, and I often do that with PSC, you will see a bigger picture. You will see this figure that I showed you before. I told you to remember it, right? And there is this big thing here in the middle. You don't have to be a geneticist to see that there is something happening there. We see the same in PBC. We see it in autoimmune hepatitis. And this is the system which actually presents molecules to the immune system. And if you look at, for instance, drug-induced liver injury here, you see exactly the same signal. And these systems in these situations present these drugs to the immune system, and you have the liver injury. In PSC, PBC, autoimmune hepatitis, we don't know exactly what these systems are presenting and what they are binding. And I think this is where the distinction between cure and improvement of the disease actually sits, because I think to cure PSC, we have to know the cause. And this is similar to celiac disease. This is the same situation, the same system presenting gluten to the immune system. In PSC, it's not gluten, importantly. We don't know. There is an X here. And I think we have to find that X to actually be able to cure PSC. And I often show this figure here talking about this. This is a picture of water. And I often use the analogy, if you came from a planet with no water and you were told to explain what's going on in this picture, you would really have a problem. Because if you don't know a rock, if you didn't know the rock, you wouldn't understand why this is so messy. And that's the situation in PSC. It's a messy situation, and we don't have the rock yet. I think we have to find the rock to cure PSC. And while we are doing that, and that's where we have our main emphasis, we would still be focusing our main efforts, and that's where the research is happening, on making this bad PSC into a good PSC. That means that people will no longer need transplant, there will be less cholangiocarcinoma risk, and that's where we want to arrive. This is a famous Norwegian painting from a fairy tale. It's an adventurous guy here. It's a troll castle in the periphery or in the horizon here. And the same painter actually painted this troll castle even closer. So maybe this is a little bit the situation and the movement we've made over the last 20 years. We're closer, we see the problem, there's certainly something bad happening in here, but we see some entrance point, and I think we are getting closer and closer to entering the core of the problem and fix it. So, 20 years of PSC research, some summary points. PSC research community, they're on a mission. They're working together, they're collaborating, helping each other, and your patient support, your strong patient support is really motivating for us and strategically important, as I said yesterday. We have new technologies all the time improving, reworking and expanding the concepts of PSC development. There is a lot of emphasis on the gut microbial contribution and this very negative discourse between the immune cells and the cholangiocytes, which is currently being assessed at high resolution. Drug development is becoming easier because we are getting better at telling success from failure, and we have better biomarkers for disease severity. Finally, surveillance and early detection of dysplasia and cholangiocarcinoma has improved, and it is working, and treatment algorithms, should there be the problem, are rapidly evolving. So this is the Oslo team for research groups, all of them working on PSC. Johannes is here, Espen was here last year, Trina and Mette are unfortunately not here. This is the International PSC Study Group, to which I owe so much, and thanks to everybody for listening.
Thank you, Dr. Karlsen. As anticipated, that was a remarkable talk. We appreciate it very much. So next up, I have the pleasure of introducing Dr. Steve Rossi. And Steve brought a wealth of experience in developing new drug therapy in liver disease when he came to PSC Partners now, I think about 2 years, 3 years? 1 year. That's done a lot in a year. But Steve's addition has been a remarkable one for our efforts in PSC Partners to try to push all of these research efforts forward. So I'm delighted to hear what Steve has to say.
Thank you. Well, thank you, Dan, and thank you, Tom, for that wonderful 20 years of where we've made progress. I stood up here a year ago when I first actually officially joined, and we presented some of the activities we were going to try and do as PSC Partners to help support and partner for research. Where we are, comparing the 20 years of what's been done is nowhere near that, but it is exciting to see what we've been able to do over this last year, and it's fun to be able to share with you where we're going and already what we've been able to accomplish. I think what's most important, and you need to understand, is you as members of this community have significantly contributed to where we are, and I think you'll see that as I go through my presentation. So last year we presented actually a similar slide where there were 5 key projects that we were taking on, either being supportive or actually leading as an organization. You've heard about this from Dr. Bolus, but there's at least some new additions. We have the grants program, which has been so important in jumpstarting both young investigators and really supporting novel research over a good 10 to 15 years, and actually has led to additional research programs. You have many of the investigators in the room who actually have received those grants, and we look forward to continuing to support that. We have the Symptom Assessment Project, which Donna Yvonne and Bryce Reeve are leading, that are looking at the development of key tools to really understand the symptoms. The registry, which under Rachel and her team has been a wonderful, wonderful source for patient information, but it's growing even further to be part of our research strategy. We had the last 2 days of the International Collaborative Research Network, which I'll talk a little bit about. Win PSC, which we really do believe is going to move the needle to actually get us closer to a cure or actually supporting that. And most recently, we actually launched a acute cholangitis survey, which really is giving us some insights into some new aspects of what the patient experiences, both from a symptom perspective and care. What's important as I'll go through this is there's a lot of information, but I want to highlight where your participation, your support have been instrumental in helping these things move forward. So we talked about our grants program, and as Chris mentioned and Tom did as well, we've got over 70 grants and $6 million that have been funded. But what's actually changed a bit, especially last year, and this is in partnership with Sarah Kirk-Culliff, who is part of the research team, to really step up how we're looking at these research grants, and importantly, bringing the patient voice strongly into helping decide which grants actually get funded. Last year, it starts with what's called a letter of intent when you look at that step one. That's where we put the call out for research proposals, and people express their interest with a brief summary of what they want to do. We've just opened the grant cycle for this year, and as of over only a few weeks, we've already gotten 17 potential letters of intent. Last year, we ended up with 35 letters of intent of high caliber research, 25 grants to review, and ended up being able to fund 5 grants of very key novel research. So that first step is based upon the strategic research plan that you all participated in over the last few years to really help identify what are the types of grants we should be funding. So you really have helped us determine what is a patient priority and the type of research we should be looking at. We then go through the reviewing and scoring, and we have a great scientific medical advisory committee, which many of the members here have been a part of, who really established through very similar ways that an NIH grant is reviewed, look at these for scientific rigor. So they give us a level and a caliber to make sure that the science we're doing is really important. The community has always given input, but this is the first year we actually had a formal scoring system that the research committee from PSC Partners looked at it from the community perspective. What was important to us? What was important to actually moving the needle from our perspective in either finding better ways to deal with symptoms, understanding the disease, or hopefully finding a cure? So the community and the patient voice is definitely integrated, and it's actually 50% of our scoring system now. We determine the grant recipients, and this year we've been able to fund 4 grants, and a key part of our evaluation is patient partnering, and this year we're actually going to be giving an additional award, and we'll do so going forward, on grants that actually explicitly really partner with the patient community. So there's even another level that we're looking at there. We start the awards, we evaluate them, and then the last thing that has to happen is that as a grant recipient, you are required to actually do presentations to the community to really share what has been found and how that actually can bring hope for new understandings of PSC. You can see these were the ways we looked at this from the community perspective. Is the work being done elsewhere? Is there good patient partnering? Does it match with our strategic plan? And what parts of the community, how broad does it actually affect? And as I said, the community review actually accounts for 50% of our scoring. Now, we've heard that first statement, Nate brought it up. It's the first thing that everybody hears. It's how all of us start, unfortunately, our treatment talks. There are no approved therapies. But I think all of us are really feeling that we're seeing a change and actually really hope that there is an increasing hope that we are moving towards finding an approved therapy. There is movement from the regulators, like the FDA, to understand how can we actually get a drug approved, and Tom mentioned some of those in what's called accelerated approval. So what you do is you take those biomarkers that Tom mentioned, and instead of doing a 5 to 10 year study, you can do maybe a 1 to 2 year study and get approved on one of those biomarkers. So it's really stepped up the opportunity to have a shorter study to get a cure. The double-edged sword is after that, you have to do a drug is on the market, available for you to take. They have to do a 5 to 7 year placebo-controlled study. So you can imagine how tough is it for a patient to decide, I could take the drug, or am I going to enroll in a trial where I might get placebo? That's been a challenge, and we know it's been a challenge for other chronic liver diseases, and we've seen what can happen if you don't actually succeed in getting that trial. The FDA can pull drugs from the market and say it's no longer available. We saw this happen with a drug just recently for PBC, so it's not like it's a theory. Just a few months ago, there's been a recommendation that a drug might get pulled from the market. So how can we as a community actually stop that from happening? We have the advantage of seeing what's happened, and through the leadership of a steering committee and PSC partners, we've actually come up with the WIN-PSC study to hopefully prevent that from happening. So the first goal of that WIN-PSC study is to develop a cohort. It's somewhat like the natural history cohorts that Tom talked about, but it's addressing even further the things that the FDA wants to see to make sure it could serve as a placebo arm in a trial. So for that 5 to 7 year post-approval study, patients could just enroll and get the active drug that's already been approved, and that long-term data can then be compared to the data in WIND, and we don't have to have a placebo arm. It's a huge jump forward. It actually encourages pharma companies to stay in studying PSC because they feel like they're not going to face what just happened with the drug for PBC. Now, we're also collecting a lot of data and blood samples every year to actually look at some of these biomarkers. We're collecting symptom data as well that will help better characterize what patients experience during the 5-year period. It's a prospective 5-year study. We're looking at 2,000 patients at approximately 20 global sites. And as I said, we do annual visits to look at some of the key biomarkers and FibroScan and look at the patients more closely. And then symptoms and events and safety are collected every quarter. What we've been able to see is the FDA identified all the problems with the PBC drug. This study actually is designed prospectively to already address those issues. Now, last year, it was a concept. This year, it's a reality. We have 6 active sites that are actually enrolling. We have our first patient at Dr. Levy's site in Miami that actually jump-started us. Dr. Hirschfield is rapidly enrolling in Toronto. But we have 6 active sites throughout both the US or North America, and our first global site in Germany is just about to start. So this has worldwide impact. In a short period of time, we have 65 sites, but with all or 65 patients. But with all these new studies coming on board, we're quickly going to see, hopefully, increasing numbers to reach our goal and be prepared for when that first drug gets conditionally approved to have data to support the drugs going forward. Now, I mentioned we had our International Collaborative Research Network, which last year we had our first meeting. We had that, which was successful. We've had a second meeting and even enhanced that further. There were 6 groups, you can see there, that looked at all different aspects about the disease, clinical trials, diagnosis, transplant, and cholangiocarcinoma. And these 6 groups were comprised of 60 of the global experts, many of them still here, including the panel that's up here, that participated to bring unique insights into what types of projects would actually be important for PSC partners to continue. The groups came together, had to come up with a proposal, but we got a wealth of other research ideas. But each group had a proposal that is going to be brought forward and hopefully be thought about to be funded to actually and prioritized for our research. There are 6 groups here. I'm not going to go through these, but they looked at a lot of the things that Tom brought up, the impact of diet, genetics, looking at PROs, looking at imaging, practice variations in post-transplant, as well as establishing a prospective data set there, and aspects of cholangiocarcinoma. Where your voice is going to matter is we're going to provide summaries of each of these at a high level. They're going to be launched on the website, and we want all of you to take a look at these if you want and actually rank them from your perspective of what is a priority proposal. So your voice will make a difference in actually what we move forward here. Now, the last thing that we have worked on is the acute cholangitis survey, and I think many of you probably participated in this. We know that acute cholangitis is a significant complication. It's poorly understood and addressed highly variably across the world. Limited data, importantly, exists not only in how it's supposed to be defined medically, but the patient experience piece of it. So as a sub-working group of the Liver Forum, Martine Walsley from UK PSC Support and ourselves from PSC Partners came together and said we were going to launch a patient experience survey that really dove into understanding the symptoms and the quality of care for acute cholangitis. It's collaborating with the medical definition group to hopefully find a path forward in better standardizing this. We launched the survey in mid-May, and in 2 weeks, we got 427 responses from this community, which is unheard of for a survey like this. So congratulations to this community for actually being able to do that. But the wealth of information that came from this is really going to help us better understand how to look at drug development and how to possibly look at monitoring and helping patients through the acute cholangitis process. It just launched on the registry, and we got another 80 to 100 patients from there. And Martine and I are working to launch this globally through the European Research Network to translate so that more countries can be involved. Now, what did we see from this? One of the key things we did do was an actual belly pain locator, and really trying to understand what everybody kind of tries to communicate, exactly where the pain is experienced, and can that help us understand that if that changes both from an incidence but also changing in severity, can that help be a measurement that actually can be quantified? What's also interesting is that patients very clearly could identify this pain different from their IBD. We actually asked that, and a high percentage of patients were able to very clearly say this is different than their IBD pain or IBD flares. And importantly, there were unique aspects of other types of pain that aren't seen in IBD. In particular, a large number of patients talked about their back pain and right shoulder pain as being something also that was very different. The symptoms that were seen were quite interesting. The most common symptom reported and persistent after a acute cholangitis episode, which most clinicians don't recognize, but actually the patients consistently talked about, was new fatigue and persistent fatigue after an episode. And this is something that actually warrants a lot more research. Anxiety was one of the things that popped up and again was persistent after their episode. So we learned a lot of things that just, and quantified them, that just weren't able to be understood, and that came from you and your voices. I think this last thing is so telling. We actually asked patients to give 3 words that describe their experience, and that word cloud visually gives you a summary of what the patients experience. So what we learned is that the symptoms survey gave us a really good starting point for understanding the dynamics of acute cholangitis. Fatigue and anxiety need to be better understood in the setting of this. And as I mentioned, we're moving forward with expanding. Our goal is to try and get 1,000 patients into this, but this is the first step to potentially developing an acute cholangitis PRO that could be used in trials. Now, you've heard about the project that Donna Yvonne and Bryce Reeve are developing. They're going to talk more about this in the breakout sessions. We have 3 unique tools that are being developed. We already know we have good tools for pruritus, but now we're working on developing a tool for belly pain or liver pain that you saw there, cognitive dysfunction or brain fog, and fatigue. And these are regulatory quality tools that are being designed the right way by Donna and Bryce to actually get these into trials that could be used as endpoints. Importantly, there are so many steps to get there, But you as the community have already been involved in the early steps, and the patient voice is part of this process every step of the way. So I think that is an important way to finish off, is that the organization of PSC Partners has already been a major player in supporting research. We're now really becoming an active partner in leading research and really helping to meet all of our mission, which is find that cure for PSC. And I think we are in a unique position as a community to actually have the strongest motivation for this. It impacts all of us directly. Importantly, it impacts all of you and your families directly. And we can't thank everybody enough, though, that is sitting in this room and helping move this forward. There's the PSC Partners staff and Ricky, and I'm proud to be a part of that team. We have our Scientific Medical Advisory Committee, who has given tirelessly over the years to helping do this, and it continues to grow through our International Collaborative Research Network, through the clinicians and researchers. The industry is an important partner here. It's how I actually came to PSC Partners, was being a person who actually was working on a drug for PSC and really collaborating. And they will continue to be a part of what we do to support this. But most importantly, you as patients, caregivers, families, and friends, your voices matter in what we do, and they really are helping move the research forward. So thank you very much, and have a great rest of the conference. Thanks.
Thank you, Steve. That was terrific. And we'll go on to our final speaker, and this is Dr. Gideon Hirschfield. And Dr. Hirschfield is the Lily and Terry Horner Chair in Autoimmune Liver Disease at the University of Toronto, and is also an accomplished and talented physician scientist who has given a lot of his significant energy toward trying to push forward our understanding of PSC, and he'll be talking to us about new therapies.
Thank you. I'm not quite sure how I'm supposed to sort of end this session or before the question and answers, having heard those amazing talks. A few observations, I guess. Ricky, I think you need a bigger room. So I guess next year is going to be in Texas or something, because the room's not big enough. I think that's another thing. And I think the other thing that's really important is that we recognize that we're all really part of an orchestra. And obviously the patients are the most important part of that orchestra. And the louder the orchestra plays, the more likely we are to be heard. Okay? And the better that we sing, and you heard that, Ricky's going to be doing karaoke tonight, okay? The better the quality of our voice, the clearer it is, the more likely we are to solve what is a very difficult problem, which is PSC. Okay? And what you heard from Tom was that we don't know the cause of the disease, but we know what the gap is in the market. We know what the goal is, which is to, people live longer and feel better. It's going to take us a while to get to the cause, but that doesn't mean that we can't narrow the gap. And we can narrow the gap if we work together. And because our orchestra is now singing better, I would say that the pace of change, and that's why the room needs to be bigger, is accelerating. And that means we can do what we saw in hepatitis C, which we've cured it to all intents and purposes. We now talk about how to get the drug to the patient, not what drug to give the patient. We can do what we are seeing in PBC, where in the US there are 3 drugs now on the market. We genuinely can do that, I believe, in PSC, and I believe the pace will pick up. So I'm not going to give you all of the new therapies, but I'm just going to give you some of the high-level concepts that go through my mind when I look at what's going on in the literature, and some of it echoes some of the things you've heard before. Importantly, when we talk about new trials and new drugs for PSC, we actually have to think about it as being part and package of our what we call standard of care. So we have a disease where we don't have the drugs that we want. What that means is that amongst awareness, the bile ducts, the cancer, the disability, is the exploration. So in the ABCDE of PSC, the exploration must be consider clinical trials. And one of the success stories of PSC Partners is in the raising of awareness has been the navigation of patients increasingly to centers that do clinical research in all forms, from symptoms to studies, because if we think trials, we'll think success. And then when we think, I always like go back to my 6 C's of PSC, and we get down to the 6th C, and that C, I always tell you every year when I get lucky enough to come to speak, the C for cure came from the patients. I said, innocently, control. Ricky Martin said, we don't want C for control, we want C for cure. Okay, which makes sense. And within that, we've got these trials that we're doing where we're trying to tackle and intervene, and I'm mainly going to talk about, where we are at the moment. Bile acid-based therapy, it's a biliary disease. We'd love to solve the microbiome, and I won't tackle that because that's a whole another conference, but we know that there's some cuckoo relationship between your bugs and your bowel and your liver. And then the immune system, some of which I'll tackle now and some of which I'll tackle later on. And you saw this slide in a smaller version. Doctors like to know that they're right, okay? Doctors believed that ursodeoxycholic acid was the simple solution to all biliary disease. We started with gallstones, we gave it to PBC, therefore we should give it to PSC. We believed and we believed and we believed, but then Dr. Lindahl said we should actually get some data. And when we got the data, we found that we believed too much, okay? And at the wrong dose, ursodeoxycholic acid is not going to help you with PSC. There may be some people who derive some harm. That doesn't mean at a lower dose it's okay, but we believed too much, okay? So we do need to find and traverse this balance between placebo and trials because we need data. I don't have to convince you in the room about how important PSC is, but I do have to convince industry, I do need to convince regulators, I do need to convince the people who pay for your healthcare, okay, that they should invest and they want to make sure that their investment is a good investment because they've got lots of things to invest in, okay? So when we look at clinical trials, we try and keep an open mind. Okay, we try our best to be enthusiastic, but we also try not to know the answer until we have the answer. That is, in fact, the rigors of being a good scientist, which is, wait for the data to answer the question, and then you'll answer the question better. So that's why participation is so important. And what about all the different opportunities? Within the slide, I've really only got the classical ideas. And what I'll talk today is really about classical ideas of trials and treatments for PSC. We need some non-classical approaches. We are going to get some non-classical approaches because we're going to bring in people to this community who are good at, we were just talking about it, good at computer science, okay? Good at solving problems without knowing much about, the disease, but know how to put together the puzzle. And that's going to help us because clearly we need to think outside of this box that I show you on this slide. Bile acids, immunoregulation, and scarring. We clearly need to think beyond that if we're actually going to have that, eureka moment. And when we have the eureka moment, we'll know, I'm sure, okay? So we're going to have to bring new ideas to the table, okay? This slide, I'm going to go through a little bit about some of the drugs. I'm going to go through aldafermin. I'm going to go through aldafermin because I confirmed with the sponsor, that there's a real push, to get new patients into clinical trials of aldafermin in primary sclerosing cholangitis. Okay, that's where Steve and I first met, and NGM have been plugging away at this. This is an engineered hormone, essentially, FGF19. This hormone talks between your bowel and your liver, okay? This engineered hormone has been trialed in fatty liver, has been trialed in PSC, okay? And what it is doing is, a souped up version of a drug that reverses toxicity from bile acids and metabolic toxicity. So it decreases inflammation, scarring, steatosis in models, okay? And this study goes back to 2019, and you can therefore work out that the trial was designed many years before that, and it took time to then recruit the study, okay? And the reason the study always stood out amongst investigators was the fact that the blood test that you know most about in PSC, the alkaline phosphatase, did not move, okay? But we saw other things that did get better. We saw less inflammation, okay? Your ALT went down, and your AST went down. And then what we saw, which was intriguing, and which was really probably the first time seen in a clinical trial, And the reason I think it's going to be one of the approaches to trialing new treatments in PSC was markers of scarring, okay, improved. And you can have different ways of measuring liver scarring. You know that you could have a liver biopsy, okay, not particularly appealing. You know that you could have an MRI scan, okay, well, that's less accessible, okay. FibroScan is more accessible in the US now, but there are blood tests that measure scarring, and what those blood tests do is measure the amount of scarring and the rate that the scarring is occurring. And there's some improvements with this drug, okay. So that's why, and just focus at the bottom of this slide, a new clinical trial of aldafermin in patients with PSC is coming to clinicaltrials.gov. And, you know, there is the hope that there'll be patients, you know, ultimately across the world, I'm sure, who will test the hypothesis that, you know, using this synthetic hormone, we can reduce bile acid toxicity, inflammation, and scarring. So that's great that we're moving in that direction. The Integra study, and I think, you know, Pliant have been here and would have presented some of this already for you, is going to present more data at the San Diego liver meeting, okay? This is an oral therapy that, and I'll show you a slide later on this afternoon, this therapy is essentially trying to reduce scarring that is triggered by your immune system. So your bile ducts are inflamed, some of the hormones go up, some of those hormones then create a cascade. That cascade leads to scarring. Bexotegrast, and trying to find the dose and the safe use of this is hypothesized to, you know, improve that scarring. So to date, the data has shown the drug to be safe. So for many of you in the room who might have been in the study, and many of my Canadian patients took part in the study, okay, there was, you know, no safety signals, which is always our first premise. And then there was, again, suggestion that it was improving scarring markers in your blood tests. And additionally, for the first time in some of the clinical trials, there's some efforts to use imaging. You know, you rely on imaging in PSC. We look at the bile ducts all the time. We need to learn how to use the imaging in our clinical trials, okay? You know, there's some possible changes with blood tests, okay? But again, really what was interesting is the fact that, you know, the patients who received placebo seemed that their scarring was progressing, whereas possibly the patients who are receiving drug, the scarring is being held back. But it takes time. You heard, this is a really long, slow disease, which is very impactful. And a clinical trial of only 3 months is a snapshot in time. And to change that balance where the river is flowing in the wrong direction, the river's flowing towards scarring and flooding, you know, and changing things all the way upstream and turning off diverting that pathway, you know, is going to take trials that take, you know, more than a few months, okay? There was some MRI data shown in the study as well. So again, we want to look at imaging, okay? What about CCL24? This is a really interesting, what's called a chemokine, okay? And this is another sponsor is working incredibly hard to see whether inhibiting this molecule, okay, can change inflammation and fibrosis, because the science, which is slow and is difficult, but is impactful when done well, suggests that this molecule is a key molecule in biliary inflammation and scarring in PSC. Okay, so this is slides provided to me from the sponsor, you know, and there's more and more data, and I believe some of this data will be shown again at the, you know, as a keynote presentation at ASLD for the patients, you know, who took part in the study, again around safety and around early signs of efficacy. Are we changing the tide of fibrosis? Okay, you know, safety is preeminent, and there were no safety signals, okay? And then, you know, we're starting to use, I already talked about blood tests of fibrosis, now we're starting to look at liver stiffness. Okay, liver stiffness is that totality measure of how stiff your liver is, and that's essentially a composite of inflammation, scarring, and what we call cholestasis, the bile duct changes. Okay, and again, you know, there is, you know, suggestion that this drug might be moving the needle, but it's just the beginning of a journey, and a difficult journey. Again, similarly using the blood tests, this molecule is making progress. In Europe, not in North America, there's a clinical trial of a drug called norursodeoxycholic acid, which actually has got really very little to do with ursodeoxycholic acid, except it's, chemically similar and it's the same company. Okay, but this is a drug that's, one of our colleagues who's, I don't think, visiting, Michael Trout, has spent nearly his whole life working on. Okay, which basically makes your bile flow better. And this is a very complex phase 3 clinical trial that I believe has finished recruitment and is now looking through the data. And so we will probably hear within the next 12 months. And a lot of your patients in Europe took part, including liver biopsy. We know you don't like it, but it is a meaningful test to see whether blood tests and liver biopsies get better. I'll skip through this a little bit because I don't want to be negative, but this study didn't work. But I don't want you to take away a study that doesn't work as saying it didn't work. In fact, it helps everybody. Within this study, okay, and there'll be more coming, I'm sure, and Chris Bolus has had to go, but he's working on looking at more of data from studies like this. Although Cilofexor, was given to patients with PSC, and look, this is what patients with PSC, it was a reasonable and representative study, and although it couldn't show that it didn't improve fibrosis, in doing this study, we showed that we could learn more about PSC. We could learn more about the rate of change of fibrosis. And if we understand the rate of change of fibrosis, we design better studies. So there is no such thing as a study that failed. There's a study that just contributes information that then helps us do the next studies even better. And we learn what we thought was exciting at phase 2, the early phase, didn't pan out at phase 3. Okay, that is why developing drugs is incredibly hard. Okay, and for the drug developers in the room, one might ask, why do you do it? Okay, but we thank you gratefully, because the 1 in 10, or in fact the 1 in 20 that do make a difference, really make a difference to patients. I'm not going to touch on Vanco. Okay, other than to say it clearly does something. There is no doubt. There's some really beautiful data coming from Pallet Trivedi, who used to be my fellow, from the UK, showing exactly what's happening to Vanco when you give it to someone with colitis, and how the patients with PSC IBD who get vancomycin, their colitis goes into remission over 3 months. So we know it's doing something. Now we have to try and tackle out, what else is it doing? And then I haven't touched upon symptoms, which are very important. IBAT inhibitors, you've heard about. We've seen the great success of IBAT inhibitors in kids. Now we're waiting for data in PSC and PBC. I listened to my colleagues already talking about elafibranor has been doing a clinical trial of fibrate, in PSC. So there's a lot going on, and I think we should all be optimistic about the future. Thank you.
Thank you, Gideon, for that wonderful talk and summary. I believe we're waiting for questions from the audience. Are there cards? Okay. I'd like to start. I'll ask you a question, Gideon. So as you look forward, we have this list of exciting potential drugs. Where is the treatment going, do you think? Is this going to be a combination of various drugs, and what do you think the future holds?
Okay, so I think that in the short to medium term, I agree that the goal would be combination therapy. The goal would be that we tackle what we understand to be the reasons people progress with PSC, which is persistent inflammation and persistent biliary injury, and we try and dampen down enough of the pathways that we move the needle. Okay, so in the absence of knowing the cause of the disease, we do know that we could reduce or delay the time that someone needs a liver transplant if they would not get as much scarring in their liver, as much scarring in the bile ducts, and as much scarring in their cirrhosis. So it does make sense, once you've identified how much the contribution of each pathway, to then combine. We are doing combined therapy in PBC. Okay? We do combined therapy in hepatitis C. Okay? We say that each pathway contributes a bit. Okay, and if we bring them together, so I would like to see combined therapy studies. They're just very difficult to do in rare diseases. Right. Okay, but you know, as a clinician, it makes a lot of sense. You'd like to dampen a bit of inflammation, a bit of scarring. Okay. Ultimately, there really are super exciting therapies which are, maybe 10 years or before you know, with gene therapies, with selectively being able to target individual genes now and individual proteins, and cell therapies. And maybe that will be something that will come our way soon.
Wonderful. Thank you, Gideon. May I ask Tom this next one, if you'd be willing to answer this. Are there quantitative metrics for interpreting MRCP results over time that we should be thinking about applying? And is that something which is going to be helpful to our patients with PSC?
Absolutely. I think I didn't spend much time on it. I couldn't cover everything. I think I see this as, you know, one of the biomarker topics within this natural history of PSC. I think that there are several aspects to it. There is the, as Gideon already alluded to, there are the functional capacities already implicit to the current methods that we're using. There is actually something we can do with what we already have. Mm-hmm. Then there are, you know, more advanced, sophisticated analysis methods, mathematical modeling. There are studies being performed, so we will know more. And then finally, and this is something we are working on, and this, you know, within radiology, this whole topic of artificial intelligence is really a big theme. It's really helping us see things in pictures, in images that we didn't naturally spot. Mm-hmm. So I think that's also some topic that we will see. Finally, I think, you know, there's also the topic of, you know, using specific contrast agents, targeting, you know, particular biological pathways. So I think there is an opportunity within what we have. There is the analytical opportunities going beyond what we have, including artificial intelligence and certainly also specific contrast agents. At the moment, there is not like a new super MRI that we're not telling you about, but certainly I think imaging is going to be important.
Absolutely. Thank you, Tom. All right, next one, as we often do, and maybe I'll kick this to you, Steve. There's a question here about the role of diet, right? And this is something that came up as one of the topics for the research network. And so the question was specifically you know, should we, or there is research that's going to be focused on nutritional food is the way they put it, but of course this gets at the whole.
I think both Tom and Gideon can contribute, but we did have discussions about, and there's a proposal to go forward to look at the impact of diet, and it's been seen in other diseases that it can have significant role in altering the various diseases. The challenges with doing studies in it is controlling for the diet for one thing, and actually controlling for it if you do a global study. There's very different dietary habits that can influence that, and translating data from one site to translating it to a routine aspect is tough. But it is, as we've heard, a high priority from the patients when there isn't a drug. The other thing that we've heard from several studies is designing and then actually enrolling in those trials has been tougher. And so looking at how the patients can give feedback on how to better do that, I think is going to be an important piece. And also the researchers deciding what absolutely has to be done to actually understand the information versus what can be done. Yeah. So I don't know if Gideon and Tom have thoughts on diet differently.
I mean, I fully agree this is a topic we need to explore and enhance further. I think there are two avenues into this. There is a lot of research on dietary patterns in general happening at the moment. What are the relationships between diet and various, you know, aspects of immune function, chronic disease influences. So we can actually, I would say, spy a little bit on that research which is already happening in the broader setting. In PSC, certainly, I think also we should use dietary interventions, even though they are difficult to control, working to understand. We know diet, I mean, for instance, in the pediatric IBD field, diet is super important as part of controlling IBD, and there is no reason to believe why this shouldn't also be important in controlling PSC and PSC IBD. I think it's linking also very closely with the research which is currently being done on the gut microbiome. So I think that if we put some responsibility on the guys dealing with that type of research, hopefully in a few years we will have more data, but it's a priority, absolutely.
Perfect. Thanks to you both. All right, Gideon, I'm going to send this one to you. So the question is related to the management of severe pruritus. What do we currently have? What does the future hold? And as part of that, someone else asked specifically about phenofibrate.
Yeah, so I mean, I think severe pruritus and PSC is a miserable thing, and it's really debilitating. It leads to fatigue, lack of sleep, it's damaging your skin. I think, PSC management and pruritus, you have to take a parallel track. You have to, first of all, always be sure that there's no biliary obstruction that you can resolve. Okay, sometimes some pruritus in PSC can be fixed by ERCP. Not often, but sometimes there's a stricture that if you dilate, the bile flows better, the itch gets better. So, we always take a dual approach. We'll have a good look at someone's MRI scan, okay? Then in terms of, what do we have at the moment, and what do we have coming? So I already mentioned what we have coming are very good drugs. The IBAT inhibitors are really very good at treating itch in cholestatic liver disease. We just need to prove it, and we need to get them, patients access to them, But we know from the pediatrics that, and from, some of the data we've seen in adults that IBAT inhibitors are very good treatments for itch. So then you have this sort of cascade of different drugs you can use. You can use a bile acid resin, cholestyramine. No one particularly likes cholestyramine. It's like drinking wallpaper paste. Okay, it works for some people, but most people don't like drinking wallpaper paste. Okay, and then you've got other drugs like gabapentin, fibrates, to your point about fenofibrate, and rifampin. Rifampin's an excellent drug for itch, okay, but you need to use it carefully. In the US, you do have access to fenofibrate. Fenofibrate, like bezafibrate, will have an impact on itch. I'm not sure that fenofibrate is the best fibrate for treating itch, but I think in the absence of bezafibrate, if I was living in the US and my itch wasn't manageable and there wasn't a clinical trial, I would certainly be comfortable giving my patient fenofibrate carefully, okay? Because I think as a class, PPARs are anti-cholestatic and that does improve itch. So it's a reasonable option to discuss with your provider.
Fantastic, thanks, Gideon. There's questions here for anyone in the group, and this is always a concern, is how about our post-transplant recurrent PSC patients? How do we get them access to some of these clinical trials and things that are...
Well, I'll give you a plug. So my colleague, Dr. Alia Gulen-Hussain, is running an international study on recurrent PSC, hosted from Toronto. She now already has 1,000 patients worth of data, so is open to any investigator. So I know that doesn't help the patients so much, but we are trying, okay? As to clinical trials, it's really difficult, okay? We're left with off-label approaches. Do I give my patients Vanco sometimes? Yes. Have I given some of my recurrent PSC patients post-transplant fenofibrate or bezo? Yes. Would I like to do a clinical trial? That'd be even better. But in each center, it's a small number of people, and I just don't know that we can yet overcome the hurdle. But I guess that's something for PSC partners can decide the prioritization and strategies.
Yeah. We did receive, again, at our ICRN group, a build upon what Alia is doing, even to expand that prospectively and collaborate potentially. So there clearly is a big interest, and that's why we had one of the working groups. As a PharmD pharmacologist, and I worked on a transplant team for 10 years, bringing drugs into the post-transplant setting. Our immunosuppression is a lot less complicated than it used to be. But there still is a whole different level of drug interactions, safety, things that just have to be studied very carefully. But I think there's too much of a barrier to saying we can't. The question is, we heard yesterday that certain sites are actually just starting to give urso almost, you would say, preventatively post-transplant to every patient. So are there ways, I'm not saying that's the right thing to do, but there may be different ways to look at drugs post-transplant, maybe more preventative as opposed to actually waiting for treatment. So it's an opportunity to look at drugs differently.
I just want to pick up on the opportunity because actually this is a setting also where you're able to intervene at the earlier stages of the disease. However, I think that, considering the complexity of the setting, probably this would be like the second round of clinical trials. You have a drug, everything is sorted out pre-transplant, it works, and then you move into the post-transplant setting. I mean, it's an obvious thing to do,
Well,
but
I think we have to get our head around technology. I mean, what we have to try and do at some point is, as clinicians and as patients, is let go of some things that we own. Because if you think about technology, a patient's data and their clinical course is all now mapped beautifully in all these electronic records. So we need to get all that information up there in the cloud from across all these centers, and we all learn from that information. And we actually have barriers, but we also have solutions. I mean, there's no reason why I couldn't follow one of Tom's patients in Oslo electronically on if I could have permission for your data to be joined up. But we're just not quite there in terms of how do we use these technologies of electronic medical records, and it can read all of the blood tests, and how do we use them? But this is where it's really powerful for rare disease. It will be possible if we can delete barriers.
But I do think I want to emphasize switching from a mindset of waiting for something to happen to treat and starting to think about prevention and what does that look like, and what does, there is a broader opportunity depending on safety of drugs to look at it, and it's a different way that drugs are being developed now. So it's unique, but it's actually a very important opportunity that you can't do in the pre-transplant setting. You really can potentially make a bigger difference in preventing. So
it'll be win number 2.
There you go. And I have no less than, am I okay to time, Ricky, still? Is that one more? I have no less than 3 questions here, all relating to the role of AI in any component of our care, of our understanding the pathogenesis. How do we harness that in a way that's positive for our patients?
No, keep an open mind. I think for the science, for Tom, I mean, AI could be very powerful. It could see things that we haven't thought of. Okay, it still needs to go back to the bench. It has to go back to the lab, but it may ask questions.
Yeah, Tom.
No, I think, I mean, as a research tool, we're already applying a lot of AI, particularly in image analysis, big data analysis. Certainly it will help. I think, having seen, technologies arrive over the last 20 years, as I said during my talk, there's always this kind of overshooting of enthusiasm. So you think that there is this new technology, and once you have this technology, everything will be sorted. I'm not sure AI will sort everything. It will be a helpful tool, and we have to carve out the niche where it's actually going to help us. But it will be there. It will be in the research, and it will also ultimately find its way into clinical practice, big clinical data assessments, prognostication, biomarker analysis. So certainly AI will be there. I think the niche is still to be defined, and we shouldn't have expectations this will solve everything, because it won't.
But it'll raise standards. I mean, what AI has the opportunity to do in clinic is to be your insurance policy for your healthcare that says, well, have you thought of? Did you notice? Have you seen that trend? Okay, so that's where AI could really help the clinicians. It could be an alarm system. Okay, because not everyone sees someone who picks up everything, but AI will be neutral to that, and it will just say, did you see your trend in platelet count, or did you see what's happening to your fibrous scan? Okay, what are you going to do about it?
But you can also even just near term, and we're learning from some of the other liver diseases, just even from a practical or an improvement perspective, God forbid biopsy remains an endpoint, but it is used clinically and an endpoint. And if we can optimize or better interpret those biopsies, there's technologies, AI technologies that are improving that. I'm not saying that's where we want to go, but at least it can be applied in different ways to take something that's maybe not as valuable and try and extract something from it.
And can you imagine the AI helping us eliminate some of that uncertainty that's such a significant part of this?
Well, we could share the uncertainty with the that would be nice. At least share it with someone.
There you go. Well, I want to thank the panelists. Wonderful talks and wonderful discussion, and thank you all.
Thank you.
Thank you. That was really wonderful. I'm sorry to cut you guys off. We would have listened to you a long time longer. So, but it's time to eat again. So we have a snack outside, out in the, I don't know if it's indoors or outdoors. I don't know what happened with the weather. Anyway, please be back at 11:15. We're going to try to start on time so we can stay on time. So enjoy the snack. Go visit the community space, the registry table, the vendors.